Gabriella, Natalie and I have chosen to advocate for naloxone to be dispensed for free without a prescription in the state of Washington. I had the opportunity to interview James Gasper, who is California's Department of Public Health Psychiatric and Substance Abuse Disorder pharmacist. California currently has many programs in order to provide free naloxone to substance abuse programs and is provided for free for all Medicaid subscribers. James Gasper has been a large part in this, as he has been involved in substance abuse programs dispensing naloxone for almost 20 years. He was able to tell me about the triumphs with the programs that he's helped and started, and also the struggles that the state is still facing with opioid addiction and overdose. I had a lot of conversation with him. I have to shorten this down to 10 minutes. My first video was over 20, so trying to just point out the biggest accomplishments that he's made in order to get naloxone into the hands of those who need it without having to pay for it. His first major accomplishment was the DOPE project in San Francisco in 2003. The DOPE project, DOPE, stands for Drug Overdose Prevention and Education Project, and this was to distribute take-home naloxone at needle exchange sites to injection users. He told me that he started with rural areas in California, as they had a lot of overdose rates and they had no access to pharmacies. Back in 2003, intranasal naloxone was not really around, and so the only way to get naloxone to patients was to give it to them through injection, which was not beneficial for most people and not very easily prescribed. Since naloxone became administrated intranasally, he said that things got much easier for him and being able to dispense naloxone to these programs. The DOPE project reported in a 6-year period they dispensed naloxone to over 1,942 patients and was used in 399 overdose reversals with an 89% success rate. He followed most of these patients, and in San Francisco, a lot of them went into substance abuse treatment programs, and so they were no longer seeking needle exchange services and not also looking at those programs. But they still had opioid addiction problems. Psychiatric clinical pharmacists is where he started to target, which is what he is. He said that they work very closely with mental illness and or substance abuse users. Therefore, these pharmacists were ideally positioned to identify patients at risk. They might be experiencing ODs themselves or witnessing their friends or family members OD, and so it was a perfect opportunity to train and provide pharmacists with being able to dispense and prescribe naloxone, take-home naloxone. One of our questions that we came up with as a group was if he has seen any encounter of opposition from pharmacists in dispensing naloxone. The 2003 DOPE project kind of rolled into new bills that he got passed. So in 2016, Gasper and other pharmacists that work for the state were able to help California pass a law to allow trained pharmacists to furnish naloxone without a physician's prescription. So what this means is that if I walk into a pharmacy and I have no prescription for naloxone, but I do have Medicare, that pharmacist, if he or she sees fit, can prescribe me naloxone on site and give me the medication. Pharmacists must screen and educate these patients, and the recognize, response and the consent needs to be signed, things like that. So for pharmacists to be able to do this, this requires a lot of training on their end. This program rolled out 3 years ago. Last year, he told me they conducted research to see how effective the program has been. Unfortunately, it is only being implemented in 23.5% of the pharmacies that he got a hold of. After doing thorough research, he realized that most of the reasons that it's not being practiced enough is there's actually lack of knowledge, that pharmacists don't even know that there's legislation passed that they can now provide naloxone. There's lack of required training, and there's a big stigma for substance abuse disorder. He thinks this is the number one reason why pharmacists aren't on board with this, is they don't want those type of people in their pharmacies. He was very big on advocating for the mental illness and drug users and trying to get the stigma of opioid addicts to change. He told me that he's working right now on getting that stigma out of law enforcement's mind, which is another topic that hopefully I have time to get into. But he said one of the biggest reasons that people are afraid to call 911 is because, yes, there is the Good Samaritan law where if they're calling to save another life, he said law enforcement still look to arrest them for priors and things like that. So the main question for the opposition for pharmacists to provide these programs was the training. So to be able to write a prescription for naloxone without a physician's order, the pharmacist must go through 1 hour of training, them and all of their employees. They must be concerned with who uses the drugs in their pharmacy. They have to take certain steps to carry it. And he said it depends on the companies. Some CVS and Walgreens are now implementing that they are carrying it. And he said it's just going to be like the flu shot soon, where if the big pharma companies like CVS or Walgreens decide we are doing the flu shot, every single employee is getting trained on how to administer the flu shot, the same thing is going to happen with the naloxone subscriptions. That if CVS, Walgreens, Rite Aid, the big pharmacy strands, I don't know what word to use there, if this is their policy, then this is what's happening. The independent pharmacists are the ones that can either decide to go through the training and carry the medication, or they can decide not to. Another big accomplishment for James was $3 million was given to the Department of Public Health to distribute naloxone to community health centers, the needle exchange programs, and then this was over the last 2 years. So the big question was, can pharmacists have this for free? And he told me no. He told me that there is no way a pharmacist is going to front the bill for this medication. It's $150 a prescription. For one prescription of naloxone, it costs $150. There's no real generic form for it. He said the FDA is pushing to get it over the counter, but the problem with pushing it over the counter is that there will always be a cost for it. He described it to me like Plan B. He said years ago you had to have a prescription. Now it's over the counter. Plan B runs about $60 over the counter. Most insurances won't pay for it anymore because you can now buy it over the counter. If naloxone goes that route, Medicare, Medicaid, any federal funding, any insurance is not going to pay for it. They might get the cost down to $50, $40, he explained. But now bystanders and family members are going to have to purchase the naloxone instead of billing it to their Medicaid insurance or their insurance company, which is a problem. It's kind of a good thing. It'll be over the counter, but it's also going to be an issue when it comes to funds. So what our main concern was is how do we get this to people for free? Another big question was individuals who use drugs and they see an overdose victim, do they have fear calling an ambulance? Now, I spoke with one of my friends who's a firefighter, and he told me that they go on OD calls often and prescribe naloxone to patients, or provide it to them. He said it's usually the EMTs that get there first on site. They have it in their cars, or the police, law enforcement have it in their cars, and they usually dispense it first. He said it's all the time. I don't know if people really are afraid down here to call. I don't know if they know how to verbiage to when they call 911 if they've had an OD. He told me recently that there was a nursing home incident where the nurse accidentally, I don't know how, one of the patients too much naloxone, and they went on that call. And he said that as soon as they gave her the naloxone, she woke up out of the overdose. So, but he told me, and still in his understanding, is that most users are still afraid to call the cops because even though the Good Samaritan law is in place, he has heard that if a user has a prior record for anything and they're there to take their friend into the emergency room, he said typically they're gonna arrest the other people there too. He said it's a huge barrier still. Or say they don't arrest them, then they now know where they are. They now know where they're living. They now know where they're hanging out. If they're homeless, they know where they've set up camp. And so it's kind of a really bad stigmatism. He said he is working with, again, he's very big on mental illness. He's working with law enforcement to advocate for drug users and to get the stigmatism out of law enforcement's mind and to really treat them as if they were sick with diabetes, that having a drug problem is an illness and not really something that they should be looked down upon. And if they need help, they need to have help, just like if their blood pressure was too high or if they were diabetic. So he was really passionate about advocating for change in mindset about overdose victims. So the biggest takeaway I got from James was the funding issue. I wanted to see kind of where California was at so we could work with the state of Washington and see differences in the dispensing. And he told me he knows Washington is pretty up to par with California when it comes to legislative and drug dispensing. He said he thinks they just need more money. The only thing I can think of is that there's no state tax in Washington, and California we get taxed for breathing. So, I mean, if $3 million came out of state taxes to give funding for naloxone to be able to be dispensed at beck and call to any mom, dad, brother, sister, patient, if they have any concern with a loved one or family member, it's easy to find a needle exchange program or a public health center, walk in and say, I'm scared for my loved one, and walk out the doors with a naloxone, prescription or it in hand. But again, he said no one's going to front the bill for them. He described it to me like blood pressure medication. He said if you walk into CVS tomorrow and you need blood pressure medication because your mom's going to die from high blood pressure, but she has no insurance, they're not going to give it to you for free. He said you need to look at overdose victims as an illness, just like, and it made a lot of sense. So I think it's just finding the funding and providing the funding to the right community centers, the right people, and then getting the word out to people who experience opioid addiction on where to find it and to have it on hand and make sure it's not expired. And it's the biggest thing that we can advocate for together. So I had a great talk with him. He's very, very passionate about mental illness and making sure that people need the right medications and get the right care.